So first, we're going to be looking at depolarization of the heart. So for the heart, here's your heart. You have your right atria, left atria, right ventricle, left ventricle. So for depolarization and contraction of the heart, you start at the SA node, which depolarizes spontaneously at around 100 beats per minute. It sends an action potential through intercalated discs down the atria all at the same time, so you're able to contract all these cells down rhythmically. And then it reaches the AV node, where there is an AV nodal delay that allows for filling of the ventricles to occur. Once the action potential makes it past the AV node, it then goes down the bundle of His, down the bundle branches, and up through the Purkinje fibers. These Purkinje fibers allow for contraction of the heart to start from the bottom and work its way up in order to get blood to go out of the top of the heart. In each individual cardiac muscle cell, you see the intercalated disc that the action potential travels through from cell to cell. The action potential travels through the T-tubule, where it has calcium-sensing feet that signal ryanodine to release calcium from the sarcoplasmic reticulum. Once calcium is released, it binds to troponin, and specifically it binds to troponin C, which then moves troponin I, which inhibits, and then troponin T, which is connected to tropomyosin. Once tropomyosin is uncoiled off of actin in the sarcomere, the myosin heads are able to bind onto the actin. And so using ATP, which helps to reload and reset the myosin head, you then break ATP into ADP and organic phosphate, and those ADP then breaks off of the myosin head, which gives a 50% power stroke, and then the inorganic phosphate also breaks off and gets the other 50% power stroke. And so the actual contraction of the heart and the force that comes is from those actin-myosin cross bridges squeezing together to get a contraction. And so once ADP and inorganic phosphate has broken off, new ATP comes and binds to the myosin head and releases myosin heads from the actin when it breaks into ADP and inorganic phosphate. In order for it to reset and grab on to actin again, you must have more calcium that binds to troponin C. So this process occurs over and over as the heart is needed to contract and the muscle has to contract. Once calcium is used up in the sarcomere, it is then released back to, it can go back to the sarcoplasmic reticulum through the use of SERCA. So phospholambin is responsible for inhibiting or allowing SERCA to get calcium back into the sarcoplasmic reticulum. So phospholambin, when activated, prevents SERCA from reuptaking calcium. And so for this, phospholambin is shut off, which allows SERCA to bring calcium back into the sarcoplasmic reticulum. So from heart contraction, we can then look at heart failure. So heart failure is caused when your heart is no longer able to get the correct amount of blood to the rest of your body in order to provide the cardiac output needed to maintain life. So you have two classes of heart failure. You have reduced ejection fraction heart failure and preserved ejection fraction. So heart failure reduced ejection fraction, or HFrEF, is systolic failure, meaning that you are unable to contract and get all the blood that is needed out of the ventricle. So this can be due from hypertension that increases backload on the aortic valve. It can also just be caused by excess fluid, which also puts more back pressure on the aortic valve. And so with HFrEF, the biggest problem is when you squeeze, you can't get the full squeeze. We talk about Frank Sterling method, which allows for greater the stretch, greater the squeeze. And so if you have a greater stretch and then you can't squeeze and get all the fluid, eventually you'll have excess blood volume in the ventricle to where you stretch too far to where you can no longer squeeze enough to get blood out. So a lot of times with HFrEF, you'll see a backup of fluid into the lungs, causing pulmonary issues and causing breathing problems and heaviness in the chest. And one of the ways that this can be taken care of is through a diuretic that gets rid of fluid, to allow for that arterial pressure to increase again, because as the arterial pressure decreases from the lack of fluid in the body, it creates more blood volume with aldosterone, angiotensin, renin. And then once that happens, then you have an increase in volume, and because you've already had a backup of volume, the problem just continues to get worse, so you have to get fluid out. You also have preserved ejection fraction, which is diastolic failure. So this is when your left ventricle is able to fill enough for needed cardiac output. This can be caused by blockages in the heart or in the arteries around it, but it does not allow for the ventricles to fill the way they need to. So unlike HFrEF, you are able to get a full squeeze, but because you don't have enough blood volume in each squeeze, you cannot keep up the cardiac output that is needed. So there are two ways. There's multiple imaging systems that are used to determine heart failure and to see heart failure. One of them is an echocardiogram. It is the use of ultrasound to see how the chambers of the heart are working. So when you look at an echocardiogram, you'll see white matter and black matter. The white matter in the lighter colors are the chambers of the heart and the muscle, whereas the dark matter is blood volume. So through echocardiogram, you're able to see how the ventricles and how the chambers of the heart are working to get blood out, because you will be able to see the blood moving in and out of the system through an echocardiogram. This also has no radiation and uses ultrasound, so it is pretty healthy to use. You also have MRI, which uses precession to align the poles in your body to allow to get an image. This also has no radiation and is used magnetism. One way to see the overall function of the heart it's called gating. So MRI plus the EKG, it gets the rapid fire imaging of the heart to produce a film of heart's function. So through this, you can see whether or not you have HFrEF or HFpEF. You can tell HFrEF if you are not able to get all the blood that is in the ventricle out each time the ventricle contracts, whereas HFpEF, it contracts and you get all the blood out, but you do not have enough blood to maintain cardiac output. These are just two imaging systems. There are many others that we can use in order to see the heart.